Hello friends, good evening. Am I audible to you? Can you hear me? So am I audible to you friends? Alright, so good evening all of you. A very happy new year from my side and everybody at Unacademy. So today we are going to have a case-based discussion, and this is our first YouTube session on retinal disorders. Today I'll be taking up a case on Coats disease. So guys, this has been considered a very important topic. As per ophthalmologists, this is very important because it creates a diagnostic dilemma. Okay, for many of us it's very difficult to differentiate sometimes Coats disease from retinoblastomas. Okay, so that is why I have taken this as a case-based question. So before that, we begin our series. Just to let you know, I am Dr. Shivani Jain, your NEET PG educator at Unacademy. I have done MS Ophthalmology from UCMS Delhi, and I have authored ophthalmology notes famous amongst FMG students. Now guys, at Unacademy, if you are already having a plus subscription, you must be knowing that we have a target 2022 batch where we are taking up morning sessions. That is already begun, and we'll continue this till May. So daily you will have coverage of all the subjects in depth. Now we also are having a FMG batch that is going to target your June exam for FMG students. So guys, you have the best faculty where you can get ample of knowledge every day. You have so many teachers which are giving you knowledge about how to crack the exams also. Now guys, in this particular course, ophthalmology will be taken for approximately 20 hours. So everything depending upon the next pattern you will be getting here. Now guys, something about this iconic subscription where you get the best of Unacademy and you get the best of Prep Ladder as well. Here you will have the video lectures and the Q Bank 2.0. You will be having a rapid revision course and daily live quizzes and tests also. Now guys, this is a new thing which Unacademy is starting with. I'm very excited for this. This is a very useful thing for students because here every fortnightly you will get a question of 60 minutes and you will have 45 questions to crack. Okay, and throughout India you will get to know where you stand. Isn't it that great? So apart from that, you will have in detail solution, the live videos where you can get to know where you went wrong. And the best part is that for your encouragement, they are giving you the prize money also to the first 4 rank holders, guys. Now you can just enroll here. It's free of cost and be very helpful for you for your preparation. So that's the code, guys, SHIVYT. You can use that code for your enrollment. No, that is all subjects together. Dr. Sarkar, that will be all subjects together. So guys, you just need to download the Unacademy Learning app and get started with that. Alright, now let's begin with our course here. Today we will have a discussion on a case-based scenario on Coats disease. So here we have a question, that is where I have given you a picture of retina and multiple answers are there. Okay, please remember, it's again multiple answer type. So let's read the question. So there is a 7-year-old boy. Okay, so the age, see the age. A 7-year-old boy was presented by his mother to your OPD with a yellowish white reflex in the pupil in his left eye. Okay, so you have a problem in the pupillary region. Now his vision in left eye was poor. It was very poor, I would say. It was just 2/60. Okay, the vision is poor. Now left eye was almost normal. He has a good vision in the other eye, in the right eye, I would say. Okay, so in the right eye the vision is good. Now on retinal examination this picture was observed There is no history of any preterm birth or any other systemic illness. Now what can be correct about his condition? So this is a small picture which I have given you, and this is a magnified view. Can you just, by looking at the picture, can you tell me what are the findings here? This is a pan-retinal picture. You have a huge view of retina, a magnified one, where almost all the quadrants of retina are being shown to you. So just by looking at that, first of all, I'm sure that you know how to see a retinal picture. I'm sure. You must know that we begin with the optic disc. So optic disc appears to be almost normal, isn't it? Disc appears to be normal. Now you see the vessels. In the central part, it appears to be almost normal, isn't it? So the central part seems to be okay. The vessels are emerging normally. But when you see the periphery, you see that there is a problem in the periphery, that these vessels are telangiectatic, isn't it? There is some vessel abnormality in the periphery. Yes, this is the first abnormal thing. Now the second thing which is very catchy is you have a lot of exudation, isn't it? Now Dr. Sarkar, this is not soft exudate, this is like hard exudate, okay? This is your lipids which are coming out from the leaked capillaries. This is not soft exudate. Soft exudate has a fluffy, paler appearance and they are pretty larger, isn't it? Soft exudate suggests that you have problem in your nerve fiber layer. But here you have hard exudates largely present intraretinally, okay? So these hard exudates, or you can say exudation, this is mainly subretinal, and some of these exudation is in intraretinal space also, okay? So this exudation, I would say it is intraretinal within the retina. This would be subretinal. How can you tell whether it is subretinal or intraretinal? So when you have a subretinal exudation, guys, you will see the vessels overlying it. That means your exudation is beneath the retina. Okay, this is in subretinal space. Now why I am saying intraretinal? Because you can't see the view of the vessels here. That means they are lying in the same plane. Okay, so you have both intraretinal exudation, you also have a subretinal exudation. So three things which we have discussed as yet: peripheral retinal abnormalities in the vessels, telangiectatic vessels. Second, intraretinal hard exudation and subretinal exudation. Now the fourth thing, which is again very catchy, is you have a problem in the macula. Guys, please look at this. You see a problem in the macula, isn't it? So you have a macular exudation also, isn't it? So you have some problem in the macula. That is why the vision is poor. Am I right? That is why the vision is poor. Okay, now let's go back to the question. So it says that there is no history of any other systemic illness and no preterm birth. So we know that this is a clear-cut case of Coats disease. Now we'll come back to the question again. Let us start discussing about the Coats disease and let's come to a conclusion. Okay. So friends, let us see how we approach to a patient who presents to you with leukocoria. Now what is leukocoria? Leukocoria word suggests that you have a white pupillary reflex. The word coria means pupil. The word leuc means white, isn't it? So you have a white pupillary reflex. That is what the complaint was, isn't it? That is what was the complaint by the mother, that there is a whitish pupillary reflex. Okay. Now when you have leukocoria, guys, it's a very old question. You must know what are the differential diagnoses. Okay. So let us quickly revise them. So congenital cataract is very, very important. Retinoblastoma, I would say this is the most common cause of leukocoria in early age. PHPV, persistent hyperplastic primary vitreous, toxocariasis, Coats disease, retinopathy of prematurity, coloboma of the disc or of the retina, old cases of retinal detachment, and some retinal abnormalities like Norie's disease. Okay, so this is your sum up list where you can have this abnormal white pupillary reflex. So you must keep these things in mind. Now, how to go about? So guys, you must take a proper history because history gives you a lot of clues. First of all, when this leukocoria is at birth, it mainly suggests that either it is PHPV or congenital cataract and nothing more than that, because retinoblastoma and rest of the things present little late. Okay, so leukocoria at birth, think about these two things. Now what about 18 months, till 3 years, you know retinoblastoma has to be the most common cause, right? Now, similarly, at preschool age, that means usually like 5 to 6 years of age, we think more about Coats disease or toxocariasis, okay, because we know that retinoblastoma does never occur after like 7 years of age. So age is a very, very, very important criteria, okay. I know exceptions can be there, but still we should know where and in what age group what disease can present. Like now the next history is when you have a history of preterm birth and low birth weight baby, so we don't have this thing, so retinopathy of prematurity is totally out. Okay, now obviously your examination plays a lot of role, isn't it? So you must undertake the baby under anesthesia. So EUA is examination under anesthesia. You must carry out a fundus examination in detail, right? So this is very, very important. Now guys, investigations, again we'll be discussing about the rest of the investigations as we proceed here. Okay, now friends, let's talk something more about Coats disease. So it was described first by George Coats. He was a Scottish ophthalmologist, and he found that in certain cases retina shows exudation and there are some vascular abnormalities in the periphery. Okay, so he described its Coats disease in 3 groups. Okay, this grouping is not very important for you, nobody is going to ask you this kind of grouping, but you should know that there is one separate entity nowadays which is called as angiomatosis retinae. Okay, angiomatosis retinae. Now what is this? It was found that massive exudation with frank retinal AV malformations is nowadays called as angiomatosis retinae. Okay, that's all you should know from this grouping given by your Coats. Okay, so nothing much, you should know that it was the angiomatosis retinae. Okay, that's all from this classification. Now guys, later on after few years, it was Leber, Theodore Leber, who found few cases having similar findings to Coats disease. That is, you have few peripheral aneurysmal vessels. Okay, so you have very, very small aneurysms in the periphery of the retina. So it was found that this Leber's disease is very similar to Coats disease, but it is a milder form. Okay, so please remember, this can be one more important question for you all, something about this Leber's multiple miliary aneurysm. Okay, so this is what? This is a variant of Coats disease, or you can say just a milder form of Coats disease. Okay, so please remember these 2 things, angiomatosis retinae and multiple miliary aneurysm of Leber. So these 2 things please remember. Now guys, for Coats disease, you must know that etiology is not known. It's a idiopathic condition, but there are few hypotheses which tells that there may be some problem at the chromosomal level. Okay, so please remember, by and large the etiology is unknown. We don't know why it has occurred. Now guys, it has been found that the disease occurs more commonly in males. Okay, we don't know why does it happen, but still it is more commonly found in males. So young boys who are there in first decade, please remember this is a very, very important clue. Okay, so a child, male child like 6 or 7 years of age, that we have in our question also, right? Now we saw there is not much familial predisposition, it does not run in families. Okay, but please remember, Coats disease can be seen in a baby who is 3 years of age and can be seen in an adult. Okay, so most commonly it's younger age group, but yes, you can see this in older age group as well. Please remember. Now one very, very important thing is that earlier the age of presentation, worse is the visual prognosis. If you have late age group patient presenting to you, the visual outcome will be good. Okay, so again, if the child is coming to you early in the age, he will have a lot of things and maybe the vision may not be even spared. Okay, so earlier presentation, worse prognosis, please remember. Now what happens, why exactly we have such telangiectatic vessels and such large exudation? So let us see what happens. Now guys, there are 2 very, very important terminologies. Please remember, The first one is sausage like shape of vessels. Okay, sausage like shape of vessels. So what happens, guys? The main problem, the main pathogenesis is that the blood retinal barrier is broken down. Okay, so when your blood retinal barrier is broken down, you will have problems in the capillary wall, isn't it? So they become leaky. The vessel configuration will change. So you have sausage like shape of vessels. Okay, so this is a very, very important question. In which pathology you see sausage like vessels? Okay, now another problem in Coats disease is that these parasites are abnormal. Okay, so you again have loss of parasites. Okay, so this results in telangiectasia. So from those leaky vessels there is an exudation of lipids, and this exudation of lipids leads to that massive subretinal and intraretinal exudation. Okay, so there is the problem in the capillary wall itself. Okay, another thing is that there is a breakdown of blood retinal barrier. So these two things are there. Now when you see these patients histopathologically, so on histology again this will be corroborating with your findings that there is a problem at the level of the vascular endothelium. There is a loss of parasite. Okay, that is why the typical appearance of the vessels. Now guys, we have discussed that the most common presentation in Coats disease is leukocoria. Okay, it is the white pupillary reflex. Now you can also see that patient is having a strabismus, a squinting eye, and obviously the vision is not very good. You have a decrease in vision. Now as I told you, if the presentation is late, the patient may even be asymptomatic for a very long period of time. Okay, so you can have varied presentations depending upon the time of presentation, right? Now guys, mainly the diagnosis is clinical, mainly. Okay, so you have to see the retina. If the child is very small, you can also do a EUA, examination under anesthesia, and if the child is cooperative, you can just see the retina through an indirect ophthalmoscope. Direct ophthalmoscope will not give you any much finding because the problem is in beyond equator. Okay, more or less in the mid periphery, right? So when you see the retina, you will mainly find the telangiectatic vessels early in the age. Okay, so telangiectasia, but here mainly it is in the temporal region. Please remember, the temporal telangiectasias are more common. Okay, you will also find that posterior pole is generally spared, right? You don't have much findings in your macula. Now as the disease progresses, there is a severe exudation which leads to thickening in the retina, and as a complication, as a result of severe lipid exudation, you may have exudative retinal detachment. So this is a very, very important question. Exudative retinal detachment is seen in cases of Coats disease. Okay, now why the patient loses vision? This is a big question. I told you that posterior pole is spared, macula is not very commonly involved, but as a complication, this exudation, it migrates, it goes towards the macula, and then you have a decrease in vision. Okay, till the time you don't have macular lesion, macular problem, your vision will be good. But as the exudation increases, as the exudation settles down in macula, there will be presence of fluid in the macula, that is cystoid macular edema. You may have macular cyst formation. You may have hard exudation collected right there at the level of macula. Okay, so these cases again have a poor prognosis. Now very, very important picture question. So guys, what do you see? This is a picture of the periphery of retina. Here you see typical sausage like vessels. Can you see that? So this is very, very, very important and a typical appearance. Okay, you can see corkscrew appearance. Okay, so twisted pin like appearance. So these are some names which are given to the appearance of these vessels. Very important. Okay, now these telangiectatic vessels has been described as light bulb telangiectasia. I told you, there are two appearances. So light bulb telangiectasia is question number 1, and this is again question number 2. So vessels take a sausage like appearance, and these telangiectatic vessels are called as light bulb telangiectatic vessels, right? Because of that bulbous terminal configuration. Let us see here. So this is your terminal bulb here. Okay, so this is called as light bulb telangiectatic vessels, bulb. Clear? Simple questions can be there. Light bulb telangiectasias are seen in. So it is seen in Coats disease. Okay. Now here again I am telling you that posterior pole is rather spared. Macula is very rarely involved. More or less you see problems in the temporal region, and then you have inferior part of the retina which is involved. Okay. Now guys, this is the staging which you need to learn. Okay, so this was given by Shields et al. Okay, so this is the staging we should know. So in stage 1 you only see some retinal telangiectasias, no exudation as such. In stage 2 you see telangiectasias with exudation. Now it can be further divided into A and B, where you see exudation not in fovea, but in B there is exudation at fovea. Okay, so our patient is lying somewhere in stage 2B, isn't it? 2B. Why? Because you see telangiectasia, you see exudation, but the exudation was in the fovea also. Okay, so our patient was in stage 2B, right? Now stage 3 you have a frank exudative RD. Okay, but here in A you have a subtotal, in B you have a total RD. Okay. Now fourth is that when you have some complications like you develop glaucoma, and stage 5 where you cannot salvage the eye, you have advanced end stage disease. Okay, so this is a brief classification. At least you learn that this is the classification given by Shields depending upon the telangiectasias and exudation. Okay, and exudative RD is in stage number 3. That is at least what you remember. Now friends, these are some more pictures where I want to show you that how this can mimic a retinoblastoma. Can you see there is a exudative detachment? Here you have a corkscrew vessel appearance here. Okay, this is a massive exudative RD. Okay, and this is your huge exudation. Alright, so this is your advanced core disease with a massive exudative RD with hemorrhages with telangiectatic vessel. So this is again one more very appealing picture of Coats disease. Similarly, here pan-retinal picture, you have lots and lots of exudative areas. Here your macula is also involved, and when you do a FFA, you see leaky vessels. Can you see? These leaky vessels are seen in your FFA. So again, an important one. Now again, bullous kind of exudative RD. Can you see? Large bullae are present. So this is again stage 4 when you have massive extensive exudative RD in cases of Coats disease. Now friends, this is one picture where you see lot of exudation in the macular region again. Alright, so rest of the things appears to be normal, but in the macula you have such kind of lesion which leads to a very poor visual prognosis. Now, you have concluded that the patient has Coats disease, but you need to confirm your diagnosis, so you will do a FFA. So on FFA, definitely those telangiectatic vessels will be leaky. So you will have a lot of leakage. Okay, can you see? These telangiectatic vessels will be of abnormal caliber and you see a lot of leaking areas. Okay, so this is your light bulb dilatation seen again at the end of the retinal vessels. Okay, please remember again. Now guys, so this is a picture of ultrasound. Here you again have a total exudative kind of RD, but you don't have a mass. So this suggests that you have this exudative RD, but you don't have a retinoblastoma because there's no mass here. Okay, so sometimes your USG-B scan is very conclusive in finding out a simple thing, whether it is a retinoblastoma or a case of Coats disease, because many a times, you know, a common age group, you know, 4-year-old baby who has leukocoria comes to you, right? So please see, you can also do a ultrasound B scan when you see a patient of exudative RD presenting as Coats disease. Clear? Now guys, sometimes when we are in doubt whether this is a case of retinoblastoma or Coats disease, because it's a very close differential diagnosis, and many a times it has happened that we have done enucleation for Coats disease because we thought that this is a retinoblastoma. So at that time MRI can be very valuable. First of all, it also tells you a globe size, because sometimes it has been found that in Coats disease the size of the globe is reduced. Okay, first thing. Now second, in retinoblastoma you see that the tumor will be hyperintense in T1 but it will be hypo in T2. But what happens in this Coats disease, it is hyperintense in both T1 and T2. Okay, so this is again an important differential diagnostic investigation where you can confirm that this is not a retinoblastoma and a case of Coats disease. Okay, so please remember this as well. Now guys, end stage Coats diseases, when you have unfortunately these secondary complications, this can lead to a neovascular glaucoma, you can have a cataract, you can have a uveitis, but the end stage disease is what? A sunken eye, that is your phthisis bulbi without any vision. Okay, so these are your secondary complications mainly resulting from ischemia. Alright, VEGF will be secreted and this thing will happen. Now finally, to conclude, how to differentiate Coats disease from retinoblastoma. Retinoblastomas, guys, occurs in younger age group, I told you. Okay, so here there is no sex predisposition, but here you see slightly older age group, but male patients are more commonly affected. Okay, now second very important thing is that I told you leukocoria is seen in both, but commonly we say it is xanthocoria in cases of Coats disease. Xantho means yellow. So it's not absolutely a white pupillary reflex. That is a common, common term which we use. But actually it is a xanthocoria. Now why this yellow look? Kindly see the difference. Okay, this is for retinoblastoma, a whitish pupillary reflex. This is kind of yellow. Now this happens because of exudative RD. So because of massive exudation, you have exudative RD and this is coming to just behind your lens. Okay, so it's a massive exudation and that gives you a yellowish kind of appearance. That is why we say xanthocoria. So please remember, it is xanthocoria in Coats disease and leukocoria in retinoblastomas. Okay, but yes, it is an umbrella term. You can cover everything in leukocoria, right? But if xanthocoria is asked to you, please say it is for Coats disease. Now telangiectatic vessels, here you have light bulb kind of appearance, and here you have the vessels which are going within the mass. Vessels dip into the mass, right? So vitreous seeding will not be there in Coats disease. It may be there in retinoblastomas. Calcification is not a feature in Coats disease, and majority of cases of retinoblastoma will be having a calcification in a mass on ultrasound. So again important, you must know that calcification, if you see in a mass, it is pathognomic for retinoblastomas. Okay, so this is one thing which I want to share with you. So this is ultrasound B scan picture where you have a mass here, isn't it? And you have some hyperintense region, that is signifying that there is a calcification. So this is definitely going with your retinoblastoma. Alright, now the last thing about the treatment modalities, guys, nothing much to learn here. It is just to show you that early stages as in stage 1 and 2, you can very well manage the peripheral telangiectatic vessels with lasers and your cryo. Okay, so you can do laser or cryotherapy in the periphery, but in stage 3, when you have exudative RD, you may consider a VR surgery, right? In stage 4, when the vision is not salvageable, you may have to take out the eyeball, and stage 5, because it's a useless eye, phthisis bulbi, no aggressive treatment is required. Okay, now after this whole discussion about Coats disease, let's go back to our question and try to solve this again. Now anybody who can answer to my question? So we now know that this is Coats disease. So do you think that a history of night blindness should be taken? Do you think it is important, night blindness? So night blindness, guys, it is important in cases of retinitis pigmentosa or other degenerative disorder, but this is not absolutely related to it. He may have an exudative RD later, guys. Yes, this is a correct statement, because Coats disease may be having a exudative RD in stage 3. Now subretinal exudation is what we see here, diagnostic thing here. But the macula is not showing egg yolk appearance. This is not egg yolk appearance, guys. Egg yolk appearance is seen in which disorder? Can anybody tell me? Egg yolk appearance, where do you see that? Anyone? So you see this in case of Best disease, isn't it? This is not an egg yolk appearance, and egg yolk appearance doesn't come so early, not in a 7-year-old boy. And the visual outcome is not so bad in Best disease early in this age. Okay, so Best disease is not like that. It doesn't present to you with such exudation and telangiectatic vessels. Okay, so we have two correct answer here, B and C. Alright guys, so this is how we approach to a patient of Coats disease. These are some very tricky things and some very important picture questions which I have shown you here. And then the last thing, how to distinguish retinoblastoma from a case of Coats disease is what is important. Alright, so guys, this is all from me today. So every Thursday we will be meeting at 8:30 p.m. and we will have case-based discussions on retina like that. Okay, so guys, I hope that you have learned something new here and you enjoyed the case-based question. So thank you very much and good night.